All right, so we will record this review session. I have in my hand here the official limited edition EMC 305 exam, and we're going to go over the content, not the questions, but the content that you'll need to focus in on as shared with your study guide. All right, all of your questions will be multiple choice and be approximately about 50 questions or so. There will be some bonus questions on myocardial infarction, pathophysiology, and treatment, as well as chest trauma and abdominal trauma. Won't be a whole lot of them, but there will be some in there. So that'll kind of give you a little bit of area as far as looking at any potential bonus questions that you got going on there. So let's kind of talk about some things in here as far as on the particular exam. So when we're looking at the different types of shock that a person may experience, and particularly with the pediatric patient, tell me the different types that can come across, as well as some of the pathophysiology behind it. Mark.
Distributive.
Tell me what distributive shock is.
So they can have anaphylactic reactions, so their vessels become leaky and fluid can't flow through it properly.
Okay. What's another type of distributive shock?
Sepsis.
And what is the pathophysiology of sepsis?
Massive vasodilation.
As a result of?
Over-review reaction.
Okay, that'll work. So again, with sepsis, what we're looking at here is that we just have a massive body-wide infection that's going on. Defenses are overwhelmed. The patient is just simply not able to fight back against it. And particularly with anaphylactic shock, what is our two biggest things that we're really, really concerned about? You mentioned one of them. There's three things we're concerned about. So one of them is massive vasodilation. What's the other one? Airway. Specifically, what about the airway? It constricts, okay? What's the third thing that happens in anaphylaxis? Say it again. And what happens with the histamine release? So vasodilation, and what else happens? Yeah, we get leaky blood vessels, okay? And so that's where the edema results from. So your primary treatment for anaphylaxis is going to be what? Epi. Okay, now remember, two drugs you need to know dosages for this exam. Pediatric dosages are Epi, and what's the other one? Atropine. Epi and atropine. For Epi, you'll need to know your dose both for cardiac arrest and for anaphylaxis. Okay? Let's talk about sepsis for just a little bit. When we have our patient that has sepsis, from a pre-hospital perspective, how would they present to you? What would be some of the signs and symptoms that you would see based on the pathophysiology that we've talked about? Hypotension would be one big thing. What would be another one? Fever. Now, what happens to the fever as sepsis progresses? Does it go up or go down?
Initially are warm, but then in advanced sepsis, they'll be colder.
Yeah, because again, those immune systems now begin to fail. And the reason that the fever goes up is that it's the body's method of trying to fight off the bacteria. And as a result of that, when those systems become overwhelmed, now the fever is no longer being able to be generated, and your patient can actually become hypothermic. So keep in mind, your patient early on, if they're still running a fever, that's actually a good thing for them, okay? So what is your responsibility? Obviously, we know the big thing is IV antibiotics once they get to the hospital. But what is your responsibility in treating a patient with sepsis? What are you going to do for them? Mark?
Raise their pressure to pressures.
Yep. And what would be the best pressor to use for patients in septic shock? Now, it's not a pressor. That's a volume replacement. Yeah, the best pressor.
Epi.
Push dose epi. Not going to ask you to calculate an epi, push dose epi for a pediatric patient. Not going to worry about that. But do know that the best pressor for septic shock is going to be push dose epi. Okay. Now, as far as your patient that is progressing from respiratory distress to respiratory failure to respiratory arrest, tell me what are some of the signs and symptoms, John, you would see in each category as it progresses. So with respiratory distress, again, in the pediatric patient, what can you expect to see?
You would see like working a little bit harder to get lungs, try to breathe.
Okay, good. So difficulty breathing. What might you expect to hear when you listen to breath sounds?
Potentially wheezing.
Potentially wheezing. Anything else? This will be open to anybody.
Specifically for exhaustion?
For distress.
Stridor.
Okay, so stridor. So keep in mind that when you've got a child that is in respiratory distress, literally, depending upon the etiology that's causing it, you could hear any breath sound. So you could go, you could hear wheezes, you could hear stridor, you could hear crackles, you could hear rhonchi. Again, in that situation. Now, if you hear rhonchi and the child is running a fever, what are you thinking is going on? Pneumonia. Okay, very good. Pneumonia is going on. Going from respiratory distress into failure, what do we begin to see? Anybody but Mark. Love you, man. Not picking on you. Now we're beginning to see some retractions, and in particular, where would you see the earliest retractions? More specific. So basically, you would see it up here in the suprasternal notch. That's where it's probably going to start. Now, as it progresses, Bella, now we're going to begin to see it down in here more so, okay? Understand that in very young children, because they got a lot of adipose tissue, you're probably not going to see a lot of retractions, but as the child gets older, they lose that baby fat, and now it's basically just skin over the thorax. Now those retractions also become much more noticeable. What else would you see in respiratory failure?
Hypoxia.
So, but how would that display itself? Hypoxia is correct, but how would that display itself?
Anxiety.
So anxiety, true, Bella. Yeah, go ahead.
So in our packet, it says distress has retraction and failure has decreased or active retraction.
So that's in that particular area there, you're actually going to see that transition. So as they're in early failure, those retractions are really ramping up because it's a survival mechanism for the child. As the child tires and they get towards the back half of retractions and they're moving, the back half of failure and they're moving into arrest, the child's going to get fatigued and it's going to stop. Does that help? Okay, good question. So what are we looking at here as far as additional things that we would see with respiratory failure? Okay, good. So here's the thing. I like what you said, Allie. A spike in your CO2. All right. And so anytime you've got a patient that has any kind of respiratory distress, put that end title on them. Okay. Don't just use it for your tubes, put the end title on them. The other thing that we're going to see here, yes. So altered mental status most definitely early on in respiratory failure, but now it's going to even progress worse. And how, particularly on the back end of respiratory failure, what might you see that would give you an indicator of altered mental status, Bella?
They're lethargic, they're not crying, they're kind of seem sleepy.
Yeah. So lethargy, no more crying. They're looking like they're getting sleepy. Got that head bobbing thing going on there. Okay. What is the pure definition of respiratory arrest?
Stop breathing.
That's a definitive, but it's actually something prior to full stoppage of breathing.
Their breaths aren't able to support the amount that they need for perfusion.
That's exactly what I wanted to hear. Okay. So your patient could still be breathing. Okay. And they could be considered in respiratory arrest. Okay. And generally what we're looking at, depending upon the age, I mean, if you've got an adult who is breathing 4 times a minute, folks, that person's in respiratory arrest. You're going to have to ventilate that person because they fulfill perfectly what Allie just said as far as the definition. With a pediatric patient, they could, particularly a newborn, they could be breathing 10, 12 times a minute, which is perfectly normal for an adult. Not so much for a child. So make sure that you keep in mind those age-related changes. For your patients, Kara, will ask you this one. For your patient, let's say that you've got a patient that parent calls you and says, child was fine, put them in a playpen to play. Let's say they're 2 years old. You get there, they've got really increased respiratory distress. Mom reports sudden onset and there's no fever. What's the most likely cause? Perfect. That's exactly what I wanted to hear. Let me go down the list here so I can get everybody involved. So, Catherine, tell me what are some common causes of seizures in kids? Fever is one. What's another one? Okay, somebody help her out. What's another cause of seizure in children? She said febrile. Epilepsy, so they can have the disease. What else? Overdose. What else? Dehydration. Okay.
Head trauma.
Potentially head trauma. We don't see so much head trauma as far as leading into seizures, but yes, that would definitely be one.
Trauma.
Say it again.
Trauma.
Trauma in general. Yeah. So, and don't forget, anytime you have a patient that's having a seizure, regardless of their age, we're going to do what? What assessment finding are we going to look for? Mm-hmm. Blood sugar. Okay. So we're going to assess that. So now, of all those causes of seizure, what's the most common? Fever. Most of the time, the febrile seizures will be over by the time you get there. I can tell you, probably count on one hand how many patients I've had that have had pediatric patients that have continued to have febrile seizures after I get there. So they're short, they're really quick, they're scary for the parents. And again, the thing we got to do is we cool the baby off. Now, remember, when we are doing cooling procedures on pediatric patients, we're going to be really, really careful of not doing what?
Cooling them too rapidly.
And what happens then?
More seizures.
More seizures. Okay, if we cool them too rapidly, now we wind up with more seizures and hypothermia. So we've taken a bad situation and we've actually made it worse. Okay. How do you, for a very young child, say 3, 4 years and younger, how do you vary your approach to patient assessment? Joe, what are you going to do different about your patient approach to patient assessment?
Rather than starting right in their face and almost right out,
Okay, why?
because they have stranger danger reflex.
Yeah, very good. So again, for most adults, we're going to go with the process of, we call it rapid head to toe. For kids, we're going to do rapid toe to head. All right. What would be some other changes that you would make in your assessment approach? Involve the caregiver as much as possible. Two things happen when you do that. Number one is that you win the confidence of the caregiver. You get that person on your side. Second thing is that it makes it easier for the child to relate to the caregiver. And so there are some things that you're going to be able to do involving the caregiver, some you're not going to be able to do. Bella.
Get on the children level.
Critically important, okay? Regardless of how tall or how short you are, you may be the shortest person in this class. Trust me, you're going to look like a giant to a 3-year-old. So get down on that patient's level that you're able to talk with them. So let me give you some airway issues and explain to me the pathophysiology between them. Let's see. I've picked on Kira. I've picked on Catherine. Let's see. All right. Richard. Epiglottitis. Tell me what you know about epiglottitis.
Infection of the airway causes swelling of the epiglottis. Most commonly, you're going to see difficulty breathing, painful swallowing, and salivation.
Okay. What's your treatment?
Rapid transport.
And?
Probably a steroid.
Not a good idea. Not a good idea. Why would a steroid treatment not be a good idea in this situation?
Oh, I don't know the answer to that.
Okay.
The treatment for it.
Okay, go with treatment then. Not a good idea.
And the slide says don't give them an IV. Why is that?
Now we're getting closer. Why do we not want to start an IV, Allie?
It's just gonna increase their distress more.
Why?
Because they're scared needles.
And what are they going to do?
Cry.
And what happens when a pediatric patient cries? Now think in the setting of epiglottitis. Use if you had your hand up.
Just going to see it. They start crying, distress, supposed to they have like difficulty breathing.
So I think we're Joe.
With epiglottitis, it's the swollen epiglottis, so they won't cough because it hurts. And if they start crying and going through that, it's going to hurt them more, one. But also, don't we give them, is it humidified oxygen?
So we want to give them humidified oxygen, okay? Giving a medication is not going to be a good thing, not because a steroid's not a good idea, not because racemic epi's not a good idea, but those meds are going to agitate the child, okay? And again, the last thing we want to do in a child that has epiglottitis is we don't want him or her to begin to cry. Because remember, that epiglottis in the pediatric patient is big, floppy, and now it's swollen. And again, if the child starts to cry, that epiglottis is going to swell even more and close off the tracheal opening. Right? And now, basically what you're going to have to do, and I've never done this, thank goodness, you're going to have to do a surgical airway on a very young child. And keep in mind, the big problem with a surgical airway on a young child is what? Other than reduced size of anatomy. The trachea can move. What else? It's an hourglass shape, yeah.
It's hard to find your landmark.
And you can't find your landmarks. All of those are true. So the big thing we want to do with this child is we want to keep them calm, humidified oxygen, cool night air. That's all well and good. That's great. Okay. When they get to the hospital, Richard, they're going to get some steroids. I can assure you. If they're having respiratory distress, they're going to get some racemic epi. But at that point in time, hopefully they're going to be in a position of where the edema is being reduced. So we don't visualize anything. We try to keep the child as calm as we possibly can. In that situation, one of the things I would tell you to consider would be to don't even pick up the child yourself. Again, coming back to what we had talked about with stranger danger and the child being threatened by you, just simply let the caregiver hold on to them, bring them out to the ambulance, and get them in the ambulance the best way that you can so that you keep the child as calm as you possibly can. All right, so that's epiglottitis. Now, we kind of touched on pneumonia a little bit ago, but tell me what you know about pneumonia in the pediatric patient. Tell me about etiology. What causes it? What are the two primary causes?
Of pneumonia,
Mm-hmm.
bacterial infection,
And there's actually three, but I'll settle for two. And viral. Anybody know what the third cause is?
fungal.
Not. I guess it could be, but not so much.
Inhalation, aerosol substances.
Yeah. So chemical pneumonia. So inhalation of hazardous materials can result in that. Don't think I've got any questions about chemical pneumonia. I typically don't ask any of those in the pediatrics. Richard?
So then what would you classify fungal pneumonia as?
Fungal, basically, remember, now fungal comes in, and the problem with fungus is the fungus itself, and that's what begins to occlude off the alveoli. The hallmark, and to answer your question, let me answer it with another question. We talked about this. What are your two hallmark signs and symptoms that you'll see with any patient with pneumonia, Allie? And?
Adventitious lung sounds.
Be a little more specific.
Thick mucousy crackles.
Called, not crackles,
Not
rhonchi. Here's the other thing about rhonchi. When you listen to crackles, quite often they'll be diffuse. You'll listen here, you'll hear them. You listen back here, you'll hear them. With rhonchi, generally it will be in one area. That's called consolidation. So clear up in here, but you listen down here. This side may be clear, and over here you've got that thick mucousy sound of rhonchi. Okay, and so it's in that one particular area. All right. So that's the thing to remember. Your treatment modality for a patient with pneumonia, a pediatric patient with pneumonia, is what? You can give a bronchodilator, okay, and oxygen, of course, okay, and then the rest of it is going to be mainly supportive, all right. Unless the child is in severe respiratory stress, probably not going to have to worry about starting a line on them. So basically, the thing we're going to look at is going to be in that particular area. Croup. What is croup? And how does it display? How does it display itself? So you got that barking cough, okay? Really loud, really harsh, and the coughing action itself, especially in young children, will fatigue them, which can add into worsening of the respiratory status. Bella? They will often be in the tripod position. The other thing that's talking about epiglottitis is that we'll see these kids in the tripod position as well. With croup, anybody can have croup, okay? With epiglottitis, we're typically looking at kids younger than 5. Adults can have epiglottitis, but it's very rare, Okay, but most of the time it's going to be younger. Yusef, you can hear stridor in severe cases again because that croup is beginning to narrow the tracheal opening because of the edema. What about laryngeal tracheal bronchitis? What is that? It's croup. Okay. What else? Now remember, it's involving the larynx, the trachea, and the bronchioles. What other finding might you see or hear with this particular disease? Okay. Definitely would have some fever going on. Good. Wheezing. Okay. Okay. Especially down in the lower lobes. Very, very good. Very good. What is your synchronized cardioversion dosing regimen for the pediatric patient?
The first one is 0.5 to 1 joules per kilogram.
And?
The second one's 2 per kilogram.
Good. Very, very good. Very good. Everybody hear that?
Oh, what's the maximum? What's the maximum dose?
So, what did you say your second dose was?
2 joules per kilogram.
And that's where you stay.
Oh, there's not like, oh, once you're at this many joules, you have to stop.
Well, at 2, whatever, 2 times 2 joules per kilogram, that's going to be your max that you're going to.
But I'm saying most drug dosages will be like this many joules per kilogram up to that.
Okay. I'm a little dense today. So, are you saying when you would stop your cardioversion?
So,
I
like,
think
the
what he's
NC might
asking-
be like 0.1 milligrams per kilogram, whatever, up to 6 milligrams or something like that.
So with your cardioversion, your first one is 1/2 to 1 joule per kilogram. Your second and subsequent cardioversions is going to be 2 joules per kilogram, and that's where you're going to stop.
Okay.
That's going to stop. Okay. Oh, what are some of the hazards of overventilation of a pediatric patient?
Barrel trauma.
So look, we can have barrel trauma, all right? The younger the child, the greater the possibility that we're going to cause lung damage. For adults, unless you're utilizing a ventilator and you just completely do something really stupid or criminal, it's going to be rare that you're going to cause barrel trauma. But for a child, definitely a possibility. Use that. Say it again. Hypotension. Why hypotension? This is important.
Vaguely down.
Vagueling down and causing what? Yep. Vagueling down, reducing preload by pressing on the vena cava and pressing in on what else?
The heart.
Say again?
The heart.
The heart. Okay. Remember, if we've got these 2 lungs on either side, we compress the heart. The heart cannot get more blood in. Therefore, it can't eject it out. So barrel trauma, vagueling down, as well as reduction in preload. Let's see what else we got in here. Tell me about the pediatric patient's respiratory anatomy. Now, we've already kind of talked about some of the things here, and the fact that the airway, the trachea, is hourglass shaped. We don't have really good cricoid membranes on the child. Actually, for a newborn, they don't have any. So, what are some of the other differences in airway? The tongue is huge. Okay, huge. All right. What else?
Diaphragm is weak.
They'll fatigue out even more, but I'm talking about primarily upper airway part. Richard?
She's better.
Okay. Bella?
The trachea shift, not walking.
So
The trachea can shift because it's not locked in.
yeah, so the trachea is very flexible. So if we hyperextend, it kinks. If we hyperflex, it kinks.
Lack of cricoid rings.
Lack of cricoid rings.
Probably get nose breathers. for certain
Why
ages,
is that a problem?
Because if they get like mucus in their nose, they'll just stop breathing. They won't even.
Yeah, they can't get air in. Good, Bella.
Positioning the airway needs to be padded, so it's neutral
Padding where?
under the shoulder.
Under the shoulders. We don't want it way up high, but we want it about an inch or two. Allie. Floppy epiglottis. Okay. If you have to intubate a pediatric patient, is their airway more anterior or posterior? By airway, I mean the tracheal opening.
Posterior.
Nope, it's actually very, very anterior. If it's posterior, it would actually make it easier for us to intubate. But the fact that it's actually out here makes it more difficult. So you got to remember that. Proper positioning, as Bella said a while ago, will help to take care of that and make some benefits for that. Normal capillary refill of an infant. Less than 3 seconds. Less than 3 seconds is what we're looking at. Less than 3 seconds. Identify the following breath sounds as either upper or lower airway problems. Okay? Gurgling. Solution for that is? What's the danger with suctioning in the pediatric patient?
Reduction of air intake.
That's one thing, so we can make the hypoxia worse. What's the second one? Potentially, but not so much. Allie?
Just damage to the airway because everything's so.
Maybe, but remember, we're going to adjust our negative pressure. Kira? Decreased heart rate. Okay, decreased heart rate. Remember, it will help them to vagal down by doing that. Okay. Snoring, upper or lower? What's the solution? Repositioning. Bronchi, upper or lower? Lower. What do we do for it?
They'll either be supportive or give some bronchodilator if they're severe.
Yep, we could get bronchodilation to help offset. Now, the bronchodilation is going to do absolutely positively nothing for the bronchi. Okay. However, what we might be able to do is to work on the back end of this and open up the bronchioles that are not affected. Because remember, what did I say with bronchi is going to be one of the big things to remember about where it is. It's localized, okay? So if we can open up some of the bronchioles of the areas where there is no bronchi, then we might be able to offset some of the decreased oxygenation. Richard.
So, I know I've transported patients on the Neo truck at UK. Assuming I'm on a truck with all the things, are paramedics able to put pediatrics on CPAP?
Getting to that.
Okay.
Hold that thought. It's a good one because we're coming up to it in just a minute. Actually, let's go to it right now. Rails. Upper or lower? Lower. What do you do for it?
Positive pressure ventilation.
Positive pressure ventilation. Can you use CPAP on a pediatric patient?
Really depends on the maturity.
There you go. That's the answer. It depends on the maturity of the child. For us, pre-hospital wise, not on a specialized unit, but for us, we're generally not going to use CPAP on someone younger than 5 years of age. Okay? Generally, all right. On your specialized transport units, like you say at UK, you probably see it on a regular basis, but it does depend upon their maturity as well. Okay. Bronchodilators, yay or nay for rails?
I've heard no. I've heard no because lost black matter.
Could. Okay. Anybody else want to go with the yay? It depends. Yes, Allie.
Sorry, I was gonna say maybe yeah, just for the same reason as the bronchi. It's not really going to do anything but stimulus COVID.
So it's not going to do anything at all for the rails itself, but it depends upon your patient. Again, what Yusef said is critically important in the fact that it could potentially cause flash pulmonary edema, which, if you think about it, we've already got pulmonary edema going on. That's what crackles is. We can make that worse. But again, if you have tried everything else and your patient is now going down that pathway of moving from failure and now they're teetering on going into respiratory distress or respiratory arrest, try it. Use it.
Given the appropriate age and blood pressure
Oh. How would you decide whether to give nitro?
than being in an age range where the average above at least 90 to 100 solid.
So in that situation, would you fall back on the AHA recommendations for differentiating between a pediatric patient and an adult patient? Why? You're right. Tell me why you're right now.
Well, I know that you just use the signs of puberty.
So in that situation, if they are showing signs of puberty, we're going to treat them as adult. And again, if they've got that stable blood pressure, then nitro would be a consideration that you would want to give them. Okay, that would be a late consideration. I myself would probably go with a bronchodilator first before I would go with that. But again, if your child's going into respiratory arrest, they're getting ready to die. So, what is the most common cardiac finding in your pediatric patients? Let me back up. Most common cardiac arrhythmia, Bella. That's early on, but what's more common than that? And what is the most common cause of sinus bradycardia in the pediatric patient? Hypoxia. Early on, they'll start tacking out trying to compensate. But again, how long can kids compensate? Not long. That's the answer. Not long. Not looking for a time frame as far as the number of minutes, but not long. That's
It'd be kind of hard to study.
It would be, okay? But again, how would we determine our child that's going from compensated respiratory distress into respiratory failure? We look at the signs and symptoms that we've already discussed in here, okay? Let's see what else. Let's say you've got a child with foreign body airway obstruction. What is the protocol for addressing that? Let's say that you've got a child that's 3 years old. You're hearing stridor. Mom says, it's kind of like the scenario we talked about a little bit earlier. Mom put him down. Now he's in respiratory distress and no fever. What are you going to do for him, Yusef? What if it does go complete? Okay. Good. So be very careful with your Miguel forceps because most all Miguel forceps are adult sized. Okay. You can still use them, but just keep that in mind. Sam?
Do you have to like
obstruction to do your back slab?
The textbook answer is yes. The real world answer, and I hesitate on differentiating between the two, is that what you don't want to do is you don't want the child to go into full respiratory arrest, because it's much easier to recover them when they still have some of that respiratory drive.
I guess it makes sense because your efforts could knock it into being a full obstruction.
It could be, but what along the same Akira?
What are some contraindications with the McGill forceps?
So with McGill forceps, obviously, if we've got any swelling, we want to be really careful in the pediatric patient because, again, McGills are adult size. We go down, and if we can't clearly see what we are grasping, don't do it, because if we go down and we grab some tissue, primarily going to be the what? Before the vocal cords. Epiglottis. Okay? We tear those, and now we have additional edema and we have swelling. So the big thing with McGill's for the pediatric patient is that if we're going to use them, we got to be able to see what's in there. Richard, you had your hand up.
I was going to say the other thing with back slabs is if it's not fully obstructed, efforts may not do a whole lot since you don't have that pressure.
So that is something to concern. So back slaps, chest thrust, okay. What is another thing that you might be able to do as maybe not a last resort, but almost at a last resort?
Suction.
If you had enough suction that you could pull it out, you're going to cause trauma to the airway. Right main stem it. Okay. Try to ventilate your patient, and if we can blow it into the right main stem, and why the right main stem? Yeah. So the right main stem, both for the pediatric and the adult, is basically kind of like this, whereas the left comes out at more of an angle. So if we can blow it into the right main stem, we're not going to get any oxygen over here into the right lung, but we can all live, even kids can live for a short period of time with just good, sufficient ventilation of one lung.
Is there any kind of technique to that, or is it just 50-50?
The way you do it is with a BVM. We don't do blind finger sweeps ever. Okay, if you see something, you can go in and grab it and bring it out, but we're not trying to push it down in, because most of the time it's going to be difficult for us to see anyway. So what we're going to do is we're going to use our BVM, and we're not going to overventilate, but in the process of ventilating, we may blow it into the right main stem. Now, how would you know if you have done that? Left-sided chest rise, left-sided breath sounds. Right side, nothing. All right? Very good. Very good. Let's see here. So let's talk a little bit about what are the signs and symptoms you can expect to see of an ectopic pregnancy?
Pain and bleeding.
Pain and bleeding. Pain where? Yusuf. Okay, so lower abdomen, will you see it? Will you find it in both lower quadrants?
Not necessarily.
It's almost always going to be one-sided. Now, that pain can radiate, but most of the time the lady will tell you it hurts here. Now, it's going over here, but this is where it hurts the most. What is your big concern with an ectopic pregnancy?
Rupture.
Rupture, which can result in what?
Severe bleeding.
Severe bleeding, life-threatening bleeding for your patient. Life-threatening bleeding for your patient. Very, very good. What's your treatment for an ectopic pregnancy? That's one thing. What else? Think trauma here, folks.
If it's a lot of hemorrhagic bleeding, you can give fluids to maintain pressure.
So if you suspect an ectopic pregnancy, and remember, all females of childbearing age are considered to be pregnant with abdominal pain until proven otherwise, get a large bore IV started on those people. Okay, this would be one of the appropriate times where I would tell you it's completely appropriate to start a 16 or even a 14 on these ladies. Okay, main reason is keep in mind that even if you're not giving pre-hospital blood, they may get blood when they get to the hospital. And the smallest gauge catheter we can run blood through is a watt. 18 is the smallest, okay? Can't get blood through a 20. The blood will do what? It'll rupture. It'll hemolyze. The red blood cells will rupture, and it'll cause a huge amount of problems with a patient. Hey, bonus question. What would be the big problem that we would see with hemolyzed red blood cells?
Hyperkalemia.
And along that same line, what else?
You're not going to have any oxygen.
Definitely not going to have any oxygen. Okay, so that's going to be one problem. Hyperkalemia is going to be a second one. Hyper what else?
Calcemia.
Hypercalcemia to a lesser degree. Excellent job, guys. Very good. So, 18 or larger for the patient. Now, remember, think along the lines of abdominal trauma. What else do you need to do for this patient?
Keep warm.
Thank you. I was going to cry, Richard, if you didn't tell me that. That's good. Keep your trauma patients, keep your bleeding patients warm, or else the bleeding will just continue to worsen. All right.
For this, would we consider pain management?
Good question. For an ectopic pregnancy, do you consider pain management? I see one nodding head here. I see another nodding head.
I would.
Okay. The key, yes.
It depends on the rupture.
Okay. So, yeah, it depends on how your patient presents. So, consider is the correct terminology that you would want to utilize. Consider that. So, again, look at your patient's hemodynamic status. If they're crashing, probably not, even if they're having a lot of pain, unless you carry what? Maybe ketamine, because ketamine does not have the same negative effects on the hemodynamic status of our patient as do the opioids. Okay. Signs and symptoms of pelvic inflammatory disease.
Pain in the back.
Yes. I'll leave it at that. Yes. Foul smelling discharge. What else? What's two of the hallmark signs and symptoms of PID? Fever would be, okay, 3. All right. Fever would be one of those hallmark signs. What else? How do they?
We'll have like a shuffling walk.
Shuffling walk and what else?
Guarding.
Guarding. Fever, guarding, shuffling, walk. Again, remember, they're shuffling because when they put the foot down, just the simple vibrations from putting their foot down causes intense pain. Okay? Most common cause of PID is STIs. All right? Your treatment of a patient with PID is what?
Rapid transport, maybe a steroid.
No steroids.
No steroids.
No, because remember, we're dealing with an infection here. We don't want to give a steroid for an infection at this point because steroids are going to do what? They're going to decrease the immune system. Are we going to do pain management? I'm not disputing what he says. I'm just asking you all. Are you going to consider pain management? What are you going to base that on? Hemodynamics. Because again, yes, pain management would be a definite consideration. But again, what type of shock are we worried about this patient going into? Septic shock. Okay. And so if they go into septic shock and they be into crash, then obviously that's going to rule it out. If they're stable, absolutely pain management, because these ladies are going to be hurting terribly, terribly bad. Okay. What are signs and symptoms of dehydration in a pediatric patient?
Urination.
Lack of urination. What else? What else can we see along that same line? I'll come back to you.
No crying.
Oh, they'll cry.
A little bit like there's no tears.
No tears. They'll cry,
Lacrimation.
but there's no lacrimation. Bella. Sunken fontanelles. Pallor. Okay. Yes. Skin turgor is terrible. Okay. Now keep in mind, the younger the child, the less reliable skin turgor is going to be. Okay, because it's not because they got so much underlying tissue.
Severe dehydration. You see
Late you would, because the cardiovascular status is now, or the system is beginning to collapse. Okay. For infants, what is your dosing regimen for fluid replacement? And for adolescents and older, 20. Okay. You give them a bolus. What's the thing that we're going to watch really closely? Lung sounds. Okay. If you hear crackles, are you going to give them a bolus? Carefully. Yeah, you can still give it, but again, again, it's kind of like my favorite saying. It depends on your patient. Depends on how severe and how widespread those crackles are. Okay, so but we do want to give it carefully. Excellent answer. Good, good, good. What is your primary goal in patients who have suffered a sexual assault? Allie. Comfort. Don't ask a bunch of questions, okay? If the patient insists, now again, in this situation, we can have sexual assault of both males and females, but I think the last statistic I saw said that females were 4 times more likely to be assaulted sexually than males were. If your patient insists on changing clothing and taking a shower, what do you do?
I would first discourage them from doing that because you need the DNA, but also just preserve the clothes if they insist on doing it.
So if they insist, and it'd be rare that you will ever respond to one of these types of situations without law enforcement already being there, although it is possible. Okay. So again, what you said is important. Again, you got to explain to the patient. Okay, you are evidence now, and this is really important to catch the perpetrator for this. If they insist on taking a shower, you got to let them because they have autonomy. Try to get them to let you sequester their clothing and especially their undergarments. How do we store clothing when we take it to the hospital?
Biobag.
Say it again.
Biobag.
We try to stay away from plastic bags. If you have access to a brown paper bag, that's what you want, okay? Now, I don't know about y'all, but I didn't carry brown paper bags on my ambulance, okay? The reason that we don't put it into either a bio bag or a plastic bag is that plastic gives off gases that will degrade the evidence rather quickly, and it can make it inadmissible. So what's our options? Use it. You could potentially wrap them in a towel. I still wouldn't put them into a bag. The other thing is, if you're going to wrap them into a towel, wrap each piece of cloth individually and keep them separate from each other. That's going to be important. I think I've only had to do that once in my career. Again, most of the time, you will have law enforcement on the scene, and most of the time, the sexual assaults that I've worked is that the patient still has clothing on, and they will collect that at the hospital. Don't ask questions. Don't. There is absolutely positively no need to do any type of what I would call an intimate exam on the patient, but just be compassionate and listen. Richard.
You may not know the answer to this, and that's fine. So then, why are like police evidence bags tend to be plastic bags?
They're almost never plastic
Are
bags.
they not?
No, if you'll ever see like a crime scene, or if you'll pull up some videos of crime scene and then bringing them out, they're always bringing them out in they're specially designed brown paper bags for evidence.
Okay.
Excuse me. Let's see what we got here. All right, so some of the things that we want to look at is know your H's and T's for pediatric cardiac arrest, in particular PEA and asystole, and more, or just as important, not more importantly, know what you're going to do to address those. Let's see. Your drug profiles that I've got in here is no for adenosine in the pediatric patient, and by the drug profile is going to be the same. But the big thing I want you to know in that is that when you would pull the trigger and utilize adenosine and not, you will not be asked to give me the dosage of adenosine. Epi and atropine are the only two drugs that I want you to know the dose on. Joe.
Since pediatrics typically have a higher heart rate, what would you say is the bare minimum that we should start to consider adenosine?
So Joe says peds have a higher heart rate, and they do. Good observation. When do we decide to use adenosine or not in pediatric patients?
If they're unstable with iron.
Bingo. Now again, remember with adenosine, if they're unstable, we're going to go with what? We're going to go with cardioversion. So you kind of got that nebulous spot in there of where you want to consider adenosine before they get really, really unstable. Okay, but your answer is correct in the fact that you look at the whole patient and you don't go just simply off of the heart rate as far as if you think they're going to begin to decompensate, then we would go with adenosine. Question. Will adenosine work in the pediatric patient if given IO? I hear a no, I hear a yes. Why do you say no, Richard?
I didn't say no.
Too slow.
Okay, it's too slow. Why do you say yes? Good answer. So it depends on where you start your IO. If you start your IO down in the lower leg, you're exactly right. Not going to work. It's going to be metabolized by the time it gets there. Okay? You go up to the upper arm, to the humeral head. Yes, you can. Okay? And it will work in there. So no epinephrine, no atropine, no, and no their drug dosage, no adenosine. Signs and symptoms of a ruptured ovarian cyst. What are we looking at here? Fever. What else?
Typically one-sided pain.
Typically, it's only on one side. Good. What else? It's okay. It's early in the morning.
That was what I had written down. There's not much on the slide.
So as far as an ovarian cyst, fever, one-sided pain, almost always painful intercourse, which the name for painful intercourse, or painful intercourse is what the medical term? Besperinia. Okay. Um, We've talked about the assessment and management of a female with abdominal pain or bleeding. One last look at the exam here. So, again, for your patients, be able to differentiate for your pediatric patients when they're moving from compensated, decompensated, and irreversible shock.
So is there any way to differentiate with field rupture variances from PID?
Yeah, well, not with 100% accuracy, but again, what did we say we would normally see with a ruptured ovarian cyst about the pain? That is different than the pain. Say it again. It's one-sided. The pain with PID is generally what? Diffuse. It's everywhere. It's also more intense. Okay, Allie?
Just knowing several people who've had that, it's also like a very, like, it's not painful before, but once it ruptures, like, it's a very sharp intense pain and they usually throw up.
Yes. And the pain diminishes. Now, here's the thing you got to remember with a ruptured ovarian cyst is your patient can become septic as a result of what? If it ruptures, what disease do they develop? Peritonitis. All right, that's your exam. Questions, comments, anything that you want to know other than the answers on the exam?
Should we just go over the dosing for atropine really quick?
So for the pediatric patient, what is your dosing regimen for atropine? And this will only be in symptomatic bradycardia. How much are you going to give? So it's going to be weight-based, okay? 0.1 mg per kg, okay? What about epinephrine? 0.01, okay? So same numbers. We're just going to move the decimal point one point to the left. Does that help, Bella?
Yeah.
Okay.
Is there like a max dose for atropine?
For the pediatric patient, if I recall, I think it's probably going to be about 2 milligrams total, depending upon the child.
Does the dose number still stay the same, but just the concentration changes for both cardiac and anaphylaxis?
Yes.
Okay.
Yes. So generally what we're looking at is for anaphylaxis, we don't really want to go above 0.5 milligrams per dose. Now we can repeat that if anaphylaxis is severe and it doesn't break or if it begins to come back. But generally 0.5 milligrams is going to be the upper limit of the 1 to 1,000 epi for anaphylaxis. Yes?
Can you go over the dosing for the joules for defibrillation on these?
Okay. So we talked about cardioversion, but we didn't say anything. Thank you. We did not say anything about defibrillation. What is your dosing regimen for defibrillation in the pediatric patient?
One to 2 joules per kg.
So we can actually go 2 to 4. We can go 2 to 4. And what I would tell you to do is you would start down on the lower end and you start with 2. And then if you have to go up to 4, that's fine. We will go up to 4. Probably, and basically anything I'm going to ask you to do would be probably based on your initial defibrillation. So if you're telling me 2 to 4 joules per kilogram for defibrillation, not cardioversion, defibrillation, you'll be okay. Other questions? These are good. So again, just to kind of recap, you'll have somewhere about a total of 50 questions. I may go up to as high as 60 for the test proper. I don't know how many bonus questions I will have in it, but the bonus questions will be from cardiology that will deal with the pathophysiology and treatment of myocardial infarction. And from trauma, it will deal with chest and abdominal trauma. Yes.
So you talked about the telltale signs for like croup, but it has a very similar presentation besides the cough to epiglottitis. What are ways we can just like definitively say it's epiglottitis?
Definitively pre-hospital wise, probably not a lot. Okay.
Absolutely.
Okay. So basically, with epiglottitis, what you will see is number one, very young child, usually younger than 5. Number 2, they will often be sitting upright in what is they're considered their tripod position. They will be drooling, okay, and they'll have a fever, okay. They'll have a fever. So that's the thing that we're looking at with epiglottitis. Again, the big treatment for that is cool night air, humidified oxygen, keep the kid calm. Bella.
Is there any questions about preeclampsia or
No, there's nothing as far as OB on there. We will pick up OB starting next week. John.
We still have the agreement where a certain percent class is 8%, we get bonus points.
I'm glad you brought that up. Yeah. So here's the thing I will tell you for this particular exam. Again, these are going to be scenario based. Again, but I'm going to raise the stakes a little bit here. So if this class hits 84% as a class, I will give you a 10% bonus on your final exam grade. Okay, that includes your bonus questions as well. So thank you for bringing that up. 84%. That's your class average. Joe, you had your hand up.
Are the bonus questions going to be multiple choice or are they more?
Everything will be multiple choice. Everything will be multiple choice. Yep. Anything else? These are good questions. Yes.
When will you be posting the recording of this review?
I am hoping to get it posted before I go into 303, which is like in about 30 minutes. If not, it'll be sometime this afternoon, but it will definitely be today. All right. Other questions?
I have one last question.
Yep.
So, and especially for the pediatric patients, I know there's a formula that you can use that's 220 minus the patient's age to calculate what their approximate maximum heart rate, like safe heart rate is. How accurate do you find that?
What's my philosophy about math for me? I'm not a math person. So I'm going to look at that. It's going to come right back to what you said a while ago about assessing for SVT. I'm going to look at the patient and I'm going to assess that. And I'm not trying to be a smart aleck or anything. It's just I try to eliminate formulas as much as I can and go with a holistic approach of patient assessment. All right. All right, guys. Let's hold on, okay? We're all struggling. John and I commiserated today when he came in for advising. Again, if you need advising, whether I'm your advisor or not, I'll be happy to help you. Just make an appointment. We'll get you done, okay?